Over to you, Dr. McIntyre.
Thank you. Thanks for joining me. Today, folks, on this session, we're going to have plenty of time for discussion. Perhaps I'll just maybe extemporaneously provide a couple of bullet points that I think will, in hopefully punctilious way, summarize what I want to get to. Ketamine as anxiolytic for the clinician, ketamine as treatment for negative valence systems disturbance for the academic, and let's talk about what this means mechanistically. Okay, this is a study that we did. Like many studies, the study was done to confirm what the clinical impression was, that ketamine could be anxiolytic for those affected by either major depression or bipolar disorder. We have 2 centers in Toronto, a center opening next week in Ottawa and also in Montreal. And we already have a center just open in Europe, the European Depression Center. And what we aim to do is, with our centers, is to provide the treatment, implement, inform best practices, but also to conduct repurposing research, mechanistic research, and so on. So let me go through this with us. Right down to business. I'm not going to give you a background of anxiety and why this is so relevant. We're coming into this journal article fully aware this is a important therapeutic target, that being anxiety in the mood disorder population. When present, it serves as a surrogate or proxy for a more complex illness presentation, and I could say inter alia suicidality. It also is a surrogate or proxy for intolerability. Said differently, amongst TRD, treatment-resistant depression, this is an exceptionally common source of distress in the population. Circa 2013, DSM-5 gives us the mixed features specifier ostensibly to instantiate the relevance of anxiety. Let's not confuse the anxious distress specifier with the mixed features specifier. If anyone on the call today knows how to disambiguate the two, please write a paper. I will nominate you for the Nobel Prize. I don't think we know exactly how to disambiguate mixed features from anxious features, but what we do know is that over-arousal or hyperarousal and or disturbance in negative valence systems is a significant unmet need in this field, and these patients don't respond as well to monoamine-based treatments. I'm not going to review extant literature on ketamine in the anxiety disorders. You know that it is a anemic database, but what's there looks promising in PTSD and OCD, but this is certainly much further behind than is the TRD space. Let me, in fact, get right down to the article itself. The clinic provides care to people. We've done several thousand infusions of intravenous ketamine. Our protocol is not dissimilar from other protocols, with 0.5 milligram or kilogram of IV ketamine for the first 2 infusions. If insufficient, at attenuating total depression symptom scores as measured by QIDS SR16, dose optimization to 0.75 takes place per kilo for treatments 3 and 4. We did not include an anxious distress specifier rating scale. Colleagues in the business have validated these types of scales, Mark Zimmerman and others. So what we did is we proxied the definition of anxious distress by taking items from the GAD-7, which is another repeat measure in the program, as well as from the QIDS SR16. Someone might say, well, hang on, how do you proxy the item losing control, which is one of the criterion items. We could not proxy that. So rather than having, as DSM required, to have 2 of the 5, we were not able to do 2 of 5. We did 2 of 4 because we did not have an item on GAD-7 or QIDS SR16 that we could proxy item 5, losing control. So if you had 2 of those 4 or more, we said you had the anxious distress specifier. This is just a very quick flow of the infusions. This takes place within about 2 weeks, 10 to 14 days. The QIDS SR is the actionable item scale in the clinic at baseline, and it's a repeat measure. GADS is done at the baseline, GAD-7, and is repeated, not at every visit, but at most visits. Our protocol is 4 infusions for an acute treatment, and then if individuals are eligible for ongoing maintenance, they will receive it. Now, this is a quick breakdown of the population. Now, right now, this was a cut of the data. Well, back when we did this analysis, this is a live breathing data set. We have people coming in on a regular basis. The numbers are higher now than they were then. And just simply put, in this sample, we had almost half, 40% of people meet the criteria of anxious distress. I've done several post hoc analyses with the 2nd generation antipsychotic studies. About 40% of those patients, up to 50%, meet the criteria for anxious distress specifier who have a mood disorder. Just over half of the individuals that we see are women in their mid-40s. And again, about 80 to 85% of our patients have major depression in this sample. Just shy of 15% have bipolar disorder. You can see that their QIDS baseline scores, they're severely ill, and they have high levels of anxiety. We categorized the 2 groups as so-called anxious distress or non-anxious distress, meeting criteria, and as expected, those not meeting criteria for anxious distress had a much lower score, not just on the QIDS, but also on the GAD-7. Our primary question was there any difference between groups on the change from the pre-treatment to post-infusion 4 on the total QIDS SR16, and the secondary questions, plural, effect on SI, suicidal ideation, as well as the effect on the GAD-7. So again, 2 groups defined as anxious or low anxious, for lack of a better moniker. These were individuals who did not meet the criteria for the anxious distress specifier, and anxious distress met the definition. What we found was, is that both groups improved on the primary question, being the QIDS SR. So this would be in keeping with some other data that are published, although preliminary, on anxious distress with ketamine in the space. In a separate analysis, what we did find is that the overall magnitude of improvement on the QIDS SR16 was greater in the anxious distress group versus the non-anxious distress group after adjusting for baseline depression symptom severity. Similarly, on the 2 secondary outcomes, there was improvement on the SI item that has relevance for reasons we all know, and that's amplified only more so in this anxious group, as well as on the GAD-7. And on subsequent analysis, we found again that the improvement on the GAD-7 as a repeat measure was also greater in the anxious distress group after adjusting for baseline GAD scores. Now, the GAD-7 was not done at each visit, so that has to be taken into consideration. Just to come back here, the GAD-7 was not done after the first infusion. The GAD-7 was done after the third infusion. So we're unable to look at the temporality of signal on GAD7 with the same degree of precision as we can the temporality of the change on the QIDS-SR. So that's something we don't know. In other words, impressionistically, it certainly is the case that anxiety does improve very quickly. In a separate analysis, just to show a bit of replication of this, we looked at three, and this was a separate analysis of our data, what I call AIA, anxiousness, irritability, and agitation, as a proxy for anxious and mixed features. And we found a very similar finding here. That's not the focus of the article I'm going to speak to today, but this is aligned with what we found looking at this trifecta that we've been, especially, I have a particular academic interest in mixed features, and for a host of reasons, including but not limited to its relevance to suicidality. So in short, we have the impression. It's been shared across the clinicians. We have about 45 people work at the center. And it's certainly been the case that there's an anti-arousal, there is an anti-negative valence system effect of this treatment. And what we also found is on the adverse event profile that there was no significant difference between groups, with one exception, that being in the anxious distress group at the third infusion, if needed, when dose was escalated to 0.75, that is the most anxious group, was more likely to report dissociation. So dissociation was more common in the anxious distress group, and with dose optimization, they had a return to the severity of dissociation reported after their first dose. So I'm going to stop there. I was told to keep it pithy and leave lots of time for discussion.
That's super. Thanks very much indeed. For those of you who've arrived late, I just want to draw your attention to the fact that after this period of discussion that we've got now, Dr. McIntyre has very kindly said that he'll stay around to on a different link, which is at the top of the chat. So, and that will be a chance for some more informal discussion of anybody who wants to join that. Roger, that was splendid and obviously important. Could I just start by asking the first question, which is just about whether you saw any relationship to the number with the people who got up to 0.75 as opposed to the people who stayed on 0.5, or was it just completely irrelevant?
It was a good question. First of all, the 60% of the full sample required dose escalation, and we have found just impressionistically, and certainly now we have data on this, we just finished, the majority of our patients, full analysis, I mean the full sample, I'm not just confining this to our discussion today, do require dose escalation to 0.75. Secondly is, in this sample that we looked at, those with anxious distress specifier, those without anxious distress specifier, those with anxious distress specifier were more likely to require dose escalation. And I don't think we're surprised by that. I don't think we should be surprised by that if we are surprised by that, because this is a more recalcitrant organism. And again, that was after adjusting for the baseline severity. As expected, those with anxious distress had a greater QIDS-SR 16 pre-treatment severity and greater GAD7 pre-treatment severity, but the dose escalation was not related to that. So this is clearly a more recalcitrant organism, so I was not surprised. What I think is interesting is that the temporality to improvement didn't seem to be different between the two groups. And that's relevant, obviously, clinically, but also maybe clinically it's relevant mechanistically. We can sort of hypothesize what that might mean and how we might translate that in conjecture. But in short, the majority required dose escalation, and that dose escalation percentage was higher in those with anxious distress. I should also mention that as part of our protocol, that individuals who come to the clinic as expected, many are, of course, prescribed benzodiazepines, and we have a protocol that they're not to take their benzodiazepines. Certainly on the day of the treatment, we try, of course, to have them hold it for longer than that, but that's not feasible for many, many people.
Well, that nicely leads us on to Steve Mandel's question, which is what role can benzos play in optimizing the mental set for anxious TRD patients about to receive ketamine infusions?
It's really a great question. And I think that there is a lot for us yet to learn empirically, not just impressionistically, but empirically about benzos. And I think everyone knows this, but just to remind you of what you know, animal work, some human work, there's 4 bullet points to consider. 1, benzos might attenuate the response to ketamine. 2, benzos might delay the response to ketamine. 3, benzos may have no impact on effect or time to effect, but instead lead to greater decay of the effect. Patients have relapses sooner. Or 4, benzos have no effect on the overall treatment outcome. And I think the 4th one seems less likely, but I don't think is completely disproven yet. So all 4 on the table. Our view is, and our impression has been, again, impressionistically, that the benzo use does attenuate to some degree, but it's hard to know whether that's, is it truly the benzo? Is the benzo just serving as a surrogate of a more complex illness? But we have asked individuals to not take benzodiazepines the day of. And that's been sometimes successful, most times successful, but often not. So a lot of these people are still taking benzos, not part of our protocol, but I left the ideal world many, many years ago. I miss that world. I love that world, but I've left there and I've never returned. I hope one day I can get back there.
So just to be clear about this, it's not your practice to give benzodiazepines to anxious patients before they have their ketamine infusion.
Correct. So they would not be the treatment we would offer our patients before. These patients are often through the process of accretion. They're often on 2 and 3 benzodiazepines, God forbid, but they're certainly on 1. And that is the regimen that they're prescribed by their care provider when they're referred to us. And so in the ideal world, what sometimes happens, we are able to get them off it entirely before they come for the treatment, which is usually scheduled a week or 2 weeks later. But usually that's not possible. And the other issue we deal with here, which is different but related, is the cannabis consumption. And, Canada has recreational marijuana, which is legal. And we've seen an uptick in the percentage of people, not just patients, but also the staff, not my staff, who are smoking weed. But the point being is that in an ideal world, we don't want them to be taking cannabis coming for ketamine treatment. But again, that's not always done. So no, the short answer is we don't prescribe benzodiazepines as a prep to reduce the anxiety for ketamine. My working belief system, rightly or wrongly, is I do think there's some attenuation effect, but I think we still need to sort that out. I don't think that's been proven beyond a reasonable doubt in the court of evidence-based medicine.
And you presumably have some data to support that. But let's move on to the next question.
Sorry, Rupert, before we move on, can I quickly ask Dr. McIntyre, is this like something that you would apply to all benzodiazepine, like independently by their half-life?
Good question. And also, can I also add to that the dose? There's a recent paper, you probably saw, that the dose matters, and that makes sense. I mean, that would be pharmacologically coherent, that low-dose benzodiazepines may have no impact on ketamine response or time to response or decay, So that's a possibility as well. So maybe there's a sweet zone that we can provide it, alleviate the stress without compromising the effect. That's still an open possibility, and that's hinted at by a very recent publication.
Thank you. Anxiety is a common side effect of ketamine. Could this side effect confound the results?
It is a common side effect of ketamine. I don't think so, because these people had pre-treatment anxiety that was quite staggering. And so in our clinic, the GAD-7 is administered before they go for treatment and as a repeat measure, although not until later in the number of infusions. So absolutely, but no, because in fact, the people who we found to be more susceptible to adverse event with ketamine was the anxious group. By the way, they did not have a higher utilization of PRN benzos during the treatment or antipsychotics during the treatment. So the direction of the signal seems to be more in keeping with the anxiolytic effect of ketamine.
So there's a further question here from Lowen Stewart, sort of relating to this, which is, can you comment on how your findings relate to anxiety or negative experiences during the treatment? And he's thinking particularly about two articles. Anxiety during ketamine infusions is associated with negative treatment responses. That's the Oust paper. And Chen et al. Suggesting happiness during treatment predicts positive outcome. So this is
it's interesting.
Yeah.
Again, our group, the group that we had, that we dichotomized into with anxious distress, without anxious distress. The with anxious distress group, as expected, had a much greater pre-treatment severity of anxiety and depression. And they were also more susceptible to dissociation during the treatment, but they did not receive more PRNs. So that's a nice point our colleague has raised. We did not, and we do not have a dimensional or self or clinician report measure of positive experience on the treatment, so I can't address that.
Okay. Presumably you're collecting data about benzos and cannabis and alcohol and other drug use.
Yeah, we are. We are, and this is a really important question for so many reasons. The iatrogenic effects of benzos with respect to their dyscognitive effects is well known. What's less well known is that they also are amplifying measures of anhedonia. So they worsen positive valence systems. We just published a paper with something I've been interested in for a long time, just published it about 2 weeks ago, that, and we found this, it was a concept that I've been interested in, that around sex stereotypes and sex biases, that male prescribers are much more likely to prescribe benzos to female patients than they are to male patients. The female prescribers are much less likely to exhibit that sex bias. So in addition to the hazards of benzos, we see much more women on benzodiazepines. I think in part there's a sex stereotype bias, how they're prescribed, but also women have more anxiety disorders and more anxiety, and they utilize healthcare more often. So there's a host of conspirators there, but we're interested in benzos absolutely for the reasons that we are, we talked about earlier with respect to it somehow attenuating or does it belie the effect of this treatment somewhat?
And I'm going to allow you space to speculate on some mechanisms here.
Yeah. Well, it depends on what our unit of analysis is, and do we want to cascade all the way down to epigenome and genome, or do we cascade up a little bit to molecular and cellular and circuit, network? Maybe to keep this succinct, I'll choose as my unit of analysis more at the circuit and network level, cognizant that that's not the only unit of analysis where we could be seeing MOA, mechanism of action. But let's just speak to that. And I think we're beginning to see a story unfold now that I'm finding increasingly compelling around brain topology abnormality. In other words, the functional and structural interconnectivity and between different subcortical and cortical brain regions. And it would seem to me that a coherent and reasonable thought, if we want to pick one of the regions or one of the circuits out for as an exemplar, might be in the default mode network, functional structural connectivity with other brain regions. We know that is an area that is abnormal in depression, linked to negative valence systems. It is highly depresso and anxiogenic in subservice rumination and other types of maladaptive cognitive phenomenology. And it would seem to me that perhaps a circuit effect is taking place. Again, I'm just focusing on that one unit of analysis where you have a normalization of circuit/network activity, including many brain regions, but one very obvious candidate to me might be the default mode network.
Okay. All right, thank you. And then we've got a question from Keelan Thomas, who says, you mentioned briefly the FEDA PTSD study at 0.5 milligrams. Have you considered using higher doses of 1 milligram that have shown even more robust efficacy in PTSD in Ross et al. 2019? Do you think higher doses with psychotherapy might increase the effect size you saw in your trials? So there are two questions there, one about 1 milligram, the other about.
Yeah, there are two questions there. Yes and yes. I do think that's the case. I don't think we're held ransom to 0.5 or 0.75. As I think most know, that was a benchmark. That was a benchmark that at least gave us a safety signal, and that's the most important signal to start with. I think, and our experience has been that we are going higher than that. We're increasing, to 1 milligram a day, and there is a suggestion that that could be more effective in some populations. The fixed dose studies in TRD are not providing adequate information to inform this discussion just yet, but our experience has been yes, the 1. And I think that the combination with psychotherapy is an excellent point. The ketamine-assisted psychotherapy or psychotherapy-assisted ketamine, whichever is your view of the world. But I do think so. But I think that, we're hearing so much about psychedelic and MDMA and psychotherapy. I think that we need to really be critical and be very ruthless as to the methodology of the psychotherapy. I do think there's been some legitimate concerns raised about the idiosyncrasies about psychotherapy that are being evaluated with ketamine, MDMA, and psychedelics. As an example, I was on a call 2 weeks ago with a large research group, and some of the investigators insisted that the therapists have to be male or female, or you must have both a male and female. First of all, I'm not aware of any evidence that socially constructed gender influences the health outcome of psychotherapy when it's manualized based. So there's a lot of this type of thing going on in the field. But as a principle, absolutely. But I would put more currency into a rigorous manualized based psychotherapy than some of the idiosyncratic psychotherapies I'm hearing about these days in the space.
That's a great place to pause. We've got some more questions, and I think that